and welcome. I'm Steve Clemens, editor-at-large of The Hill. Thanks so much for joining us for our forum today titled Making Medicare Work Better for Patients. Before we begin, I'd like to thank our sponsor, Pharma, the Pharmaceutical Research and Manufacturers of America, for supporting today's event. We'll be taking a close look at the current debate surrounding Medicare modernization and what that could imply for patients. How do we cut costs for patients while also encouraging drug innovation, research, and development? Should the government be able to negotiate drug prices in Medicare? And what is lost if they do? What can Congress do to lower costs for prescription drugs for seniors and people with disabilities? And how can Medicare be improved to help patients access care and afford their medications? Before we bring on our fantastic speakers to these questions and more, a few housekeeping notes. You can tweet us at The Hill Events using the hashtag #TheHillMedicare. That's a first for us, The Hill Medicare. We're broadcasting live and we'll be taking your questions throughout the program. As with any live stream, and I always laugh at this, they say, you know, if you have any troubles, just refresh the page and it should mix most of your problems. It occasionally works for me. I'm sure it will for you. We're now kicking off the program with the newly minted Deputy Administrator and Director of the Center for Medicare, Dr. Meena Seshamani, excuse me, Dr. Seshamani. Dr. Seshamani, please excuse the butchering of that, but it's so great to be on with you today. Thanks for joining us. Look, I'd like to just sort of start out asking, you know, when it comes to the social contract with patients and the importance of Medicare, which you're running, I'd like to know for you, what do you feel needs to be tweaked or changed when it comes to delivering high-quality health outcomes that we're not doing today from your perspective?
Well, thank you so much, Steve, for inviting me to be here with you today. And certainly it is an honor to lead Medicare during this pivotal time for our nation's health. And, you know, to your question, Medicare certainly has a central role to play in President Biden's vision to build back better. We must advance health equity, drive high-quality person-centered care, and promote affordability and sustainability. And we must do this through Original Medicare, Medicare Advantage, Part D drug coverage, and our transformation initiatives through our Innovation Center. These principles are evident in some of our recent rules. So, for example, we made a commitment to increasing data on health disparities in our proposed inpatient prospective payment system rule, with a particular focus on maternal morbidity and mortality, which we know particularly impacts women of color. We've also expanded access to telehealth services for beneficiaries who have behavioral health needs in the physician fee service fee schedule proposed rule. And I can say personally, as a physician, I know the difference that leveraging telehealth has made for our patients and our providers. For example, enabling someone who previously had to take multiple buses and spend hours to get to clinic, instead being able to engage from their home. And we're also increasing enforcement of our hospital price transparency regulations so the market will have the information it needs to improve competition. Now, to one of the areas you mentioned, prescription drugs is an important area for us to address. Americans pay 2 to 3 times more for their prescription drugs than people in other wealthy countries, and nearly 1 in 4 Americans struggle to afford prescription drugs. President Biden's Build Back Better agenda calls for the lowering of prescription drugs for Americans by letting Medicare negotiate drug prices. And this is something that is overwhelmingly popular and bipartisan. I also firmly believe that we must continue to innovate in our programs. So thanks to the Affordable Care Act, the Center for Medicare and Medicaid Innovation has been testing ideas to bring better health care to beneficiaries in a more affordable and sustainable way. And we in the Center for Medicare will partner very closely with them to bring about truly innovative solutions to some of our major healthcare challenges. And I say all of this from my perspective and experience also as a physician who has very recently taken care of patients. I have seen firsthand the impact on patients, on their families, on their communities when the system doesn't work for them.
Right.
I am committed to ensuring that we will achieve these objectives in partnership with our beneficiaries. They really do have to be at the center of everything that we do.
Well, Dr. Seshamani, one of the things I have learned in this field after having done probably hundreds, if not thousands of forums, is that there are lots of shades of gray. There are a lot of nuances, a lot of fragility. And you were just talking about, one of these issues that I've been reading different sides, actually, and it's like gravity working different sides, about government being the one to negotiate with industry on the price of drugs. And some say when that some argue as the Kaiser Foundation found that that's popular. If you look at Morning Consult, you find a lot of people kind of have a slightly different view. The Morning Consult poll, has people worried that, perhaps some of the access they have, the robustness of access they have, that would be more fragile. And so I'm just wondering whether we are looking for formulas of approach that may undermine what has largely been working at a level. And I'm just wondering, whether you're sensitive to those dimensions as well. This is, Disability Pride Month, and I've been reading a bit that those that are disabled are worried if you were to change that formula, a lot of the access to the drugs on the disabled front, that foundation might become more wobbly.
Well, I think high-cost prescription drugs remain a significant challenge for the nation, as well as for Medicare beneficiaries who rely on these therapies to prolong life. A lot of the work in our innovative care models that are trying to improve people's health, avoid unnecessary hospitalizations, avoid ED visits, if the prescription medications that people take to stay healthy are expensive or unaffordable, this presents a huge barrier to people being able to stay healthy and for all of us to make progress on in improving our system. Sure. So I think that we need to consider, access, quality, affordability all together as we are evaluating, how we move forward. And certainly, all options are open.
Right. Later in the program, we're going to have Randall Ruzza, the CEO of the National Health Council, and really looking. So maybe this is appropriate for him. But sometimes I wonder, could we just have a dinner? I mean, this is going to be really naive. Get our friends from the pharmaceutical industry, get the insurers, get the pharmacy benefit managers, get various players, get the generic, and then have a discussion. Get patients, back in this, and discuss this ecosystem of how we can actually achieve better health outcomes in the system at prices that make sense for people at the corner. And so I'm just wondering, when you kind of look at this, and oftentimes we're looking at drug brand names, but insurers and deductibilities, the deductibles are part of the story. PBMs are also part of the story that are negotiating the price, and some are saying, hey, a lot of that money that they're saving with this is not ending up rebated or in the pockets of the patient where it might land. And so I'm just wondering whether we need to broaden the aperture a bit when we talk about affordability of drugs, and are there not other I don't know how to put it, complicit parties that we should be bringing into this?
Well, I mean, certainly the direction provided in President Biden's executive order on promoting competition in the American economy, really calls on working around the pricing of prescription drugs and biologics, enhancing domestic pharmaceutical supply chains, et cetera. And so where we can really try to achieve value in our healthcare system, really support people to stay healthy, really spend money in a smarter way. These are all the tenets that we have to take with us moving forward. And again, to come back to the theme of this event, making sure that people are at the center here, that people are able to stay healthy, that they're able to afford their treatments, and that they're able to stay well and enjoy life and be with their communities, et cetera. So I think really being able to keep that true north in mind is very important.
I love that vision. And along those lines, one of the odd moments, and I'm just waiting really desperately to actually see the text of this infrastructure bill, which we're all waiting to hear from and to see what's included. But there are a couple of tremors out there that think that some of the elements that might have been in your department that could help those patients get greater rebates or returns, at the drugstore counter, maybe, something that they draw money from that to help pay for the infrastructure bill. Is there truth to those rumors? Do you know the status of that as this bill is being negotiated?
I can't speak to any of that. What I can say is that I look forward to continuing to work on these issues and look forward to partnering on them.
Well, that's a great answer. And I can tell you're having fun in this job. But we've got a couple of questions from our audience, and I want to ask Paul. Paul?
Hi, Paul Kelly here with the Livingston Group, a lobbying firm here in Washington. Thank you, Steve. I want to congratulate you and the Hill newspaper for once again having a great webinar on a really important healthcare topic. I wanted to ask about value-based care. There's been such an emphasis in recent years on value-based care in Medicare and other healthcare systems rather than the old fee-for-service system. I'm wondering if the panelists think that that's going to continue, what incentives might be put in place to help that be successful, and most important, whether that's benefiting patient care. Thanks.
Thank you, Paul. Good question.
Yes, thank you, Paul. Certainly, the Center for Medicare and Medicaid Innovation has been transforming both Medicare and Medicaid to improve the delivery and payment of care. And, especially through accountable care organizations where we can have people involved in having quality and accountability for the cost of care together. Certainly, programs such as these will continue to be utilized in the Biden-Harris administration to bring about really innovative solutions. And as the Center Director for Medicare, I really believe in a very strong partnership here where we can work together across the continuum of care, thinking about how we can have the person at that center. This also gets to issues of health equity. How do we make sure that we are addressing how we can best support people and keep people healthy and really have the health system work for them? And we can do that through a lot of these innovations that really run the gamut from, some of the models in CMMI to some of the ways that we work in the day-to-day runnings of our programs.
Well, thank you. We have a question that's come in by Twitter from someone I have great respect for what he's doing, this Congressman Patrick Kennedy. And Patrick Kennedy writes, please ask why the Medicare fixes out there don't include mental health and addiction coverage despite soaring overdose numbers and documented health impact of COVID. Is brain health not health? I think that's an important question, and as we sort of begin looking at, what we were beginning to do to look at wellness, look at value-based care, look at the efficacy of treatments and whatnot. Shouldn't mental health somehow be within the sandbox that you have direction over now?
Absolutely. And in fact, in the physician fee schedule, we have expanded telehealth services for behavioral health needs. So certainly behavioral health is front and center. As mentioned, this really has come to the fore with the pandemic, but was really there beforehand as well. And so this is something that we will continue to focus on.
And Dr. Seshamani, another question that has come in by Twitter, and asked about something I really don't know very much about, but it sounds interesting. It's about, the concern that there's an under reimbursement level of about 8 to 9%, after that industry feels that when it comes to the cost of care reimbursement, that there's this 8 to 9% gap nationally. But in some places in the country, like Northern California, according to this person, it's a wider gap. And so that puts pressure on commercial rates, et cetera. So I'm just interested, again, this comes to payments and reimbursements, and I know it's a very wonky issue, but as we begin looking again at how we cover more Americans and make sure, to come back to your original point, that we're reaching patients where they are there things that we need to tweak in those arrangements or be aware of that our audience may not be aware of?
Well, I think certainly, around making sure that we are advancing health equity, we are looking at quality person-centered care and affordability and sustainability, and really evaluating in our programs where there are improvements that we can make, small or large, to be able to drive those objectives. That is certainly very important.
Well, Dr. Meena Seshamani, Director now of the Center for Medicare and Deputy Administrator, thank you so much for joining us today, and we hope you'll come back.
Thank you for having me.
I had a chance to speak with my next guest a short while ago. Ruud Dobber is Executive Vice President and President of Biopharmaceuticals at AstraZeneca. Take a listen.
Ruud, it's so great to be with you today. What I'm trying to get my head around and to understand it is, what is the magic? What are the elements that come in to make biopharmaceutical exploration and innovation really work? And as you describe it, what can get in the way of that?
First of all, We are literally a science-led company. And we need to realize that despite all the progress in tens of years, there's such a high unmet medical need for so many diseases. People with chronic diseases, people do not realize that hundreds of millions of people around the globe are suffering daily from a disease, whether it is respiratory disease, cardiovascular disease, diabetes, kidney disease. And once again, despite all the progress, there is still so much we can do as an industry, as an individual company, to try to help those patients to move from a so-so life to a much better life. And that's our passion. And the only way you can do that, in my view, in our view, is to follow the science and to be almost obsessed in order to find solutions for so many patients around the world.
Ruud, what you just mentioned, diabetes among many of the drugs that you think, or the ailments that humans have that we have to respond to. And I understand that AstraZeneca has a new product. It's called Bydureon B-Size, if I'm saying it correctly. And this responds to type 2 diabetes in youth. And I guess, what I'm interested in as you go in and you've been trying to develop a drug, one of the things I want our audience to know is that not everything is a sure thing, that sometimes there are risks involved, that AstraZeneca is putting its resources involved. Can you tell us a little bit about how you get the equities right and how do you get the success in something like a diabetes responsive drug?
Yeah, it's an excellent question. And the way I always explain it is we are in the business of innovation. So there's high risk and potentially high reward for patients and potentially also for the owners of the company, the shareholders. But most importantly, for patients, we are really trying to push the boundaries of science. Diabetes is a worldwide pandemic, almost like COVID-19 is a worldwide pandemic. Too many patients are suffering from too high blood glucose. And this specific product you are mentioning is a so-called GLP-1, and it is reducing the blood glucose in a very nice way. It's an injectable once a week. And specifically for this product, it's now also approved for children. And that has a huge advantage for so many children already suffering from diabetes. But science is exciting. Science is complex. Sometimes you fail. And if you don't fail, you're not innovating enough. So it's that nice equilibrium that sometimes you're successful, but sometimes you need to take it for granted that you are less successful.
Well, I've been trying to encourage some in the pharmaceutical industry to start, talk about some of the things that don't work out so that there's a better understanding of, risk and reward in the process. But there is a lot of attention right now on the question of affordability of drugs, on what patients are paying at the counter, how to get all of these elements right. And I'm aware that that a lot of the focus has been on drug companies. We have pharmacy benefit managers, we have Medicare and other players in this. And there is a piece of legislation out there called HR3 that I know you've addressed. And I'm just interested in what you think what are your concerns about how we approach drug pricing in a constructive way, and what would undermine approaching it in a constructive way?
Yeah, first of all, I think we are in violent agreements that overall out-of-pocket costs in the United States are too high. Although I'm working and living for a long time now in the United States, in my heart, I'm still a little bit European. And I think it's not a sustainable way moving forward that too many patients in the US cannot afford their medicines. In the end of the day, we have only one ambition, one purpose: to bring innovation to patients. And a patient who cannot afford their medicine is a lost patient. It's a pity. Equally, we are working closely now with the Biden administration to find solutions. There's an enormous amount of rebates going to PBMs. More than $180 billion on an annual basis are going to PBMs. Those dollars are not ending up in the pockets of patients. And we think that there needs to be a redistribution of those dollars back to patients. Now, equally, we need to realize that medicines have a clinical value, but let's not underestimate the economic value of medicines. And therefore, we are huge proponents of what is called value-based agreements. Let us show us the economic benefit of our medicines. If patients are getting treated with medicines and they are not no longer going to the hospital, they are no longer not in the work environment. Those are clear benefits for patients and society, and hence we are strong proponents in order to have a bigger role of value-based agreements moving forward.
Now, were we not going towards value-based agreements and looking at precision medicine and how to bring these various elements so that it was patient-specific, and so that way both the costs were being more closely connected to wellness and outcomes? What has gotten in the way of that, Ruud? I mean, the picture seems to me to become, much more convoluted. I remember that clarity, but what's happened to kind of make that more obscure?
Yeah, value-based agreements can only work when also PBMs are willing to consider that as an alternative. Literally, it takes two to tango. PBMs are great organizations. They are sitting on an enormous amount of data, but sometimes I'm missing the sense of urgency of PBMs in order to change the model. And as long as that model is still very favorable for PBMs, nothing will change. And my clear ask to politicians and policymakers is to have a mature discussion in order to change altogether the system, which will, in the end of the day, then benefit patients.
One of the other drugs that AstraZeneca is developing, and I have to admit I'm very interested because I know friends that suffer from lupus, is called Saphnelo. But another reason I'm interested in is we had this, this episode a little while back about azithromycin and lupus, and it was concerns about COVID, and there was a sort of sense that there was now going to be a shortage in supplying needed drugs to a certain group because of the COVID scare that was underway. I'm interested, there hasn't been any real response in lupus in 10 years. What has driven AstraZeneca to invest in this, and what are the dynamics of it? Why was it so slow? And should our public be concerned about not having enough options to treat ailments like lupus? What can we do to enhance the options?
Yeah, Steve, it's another great question. We need to realize that the lupus area is probably one of the most difficult areas for drug development. Some experts are really calling it the graveyard of drug development. And it took us a lot of resilience in the end of the day to find a new mechanism which can potentially help patients with lupus. And you rightly said it's a devastating disease. Multiple organs are affected by the own immune system, and hence those patients are suffering massively. It's a disease with a high prevalence in women, and within women, especially the African American population. So the product is not yet over the finish line, but we have very good hopes that the FDA will approve it very soon, and also in other geographies. And at least we have a new option for physicians to treat those patients who are now hardly have any options in order to get treated.
Ruud, let's just go one step further on the kind of broad question. I'm fascinated, by drug development, Saphnelo, which I know is up before the FDA now. But when you kind of look at that innovation system, on one side and developing it, but patients on the other, because I know patient advocacy groups are very, very interested in this, and cost becomes an issue. How do we get those elements inside the United States right so that you get to do what you're best at, patients get what they need, and the government's playing the right kind of role it should?
No, first of all, Steve, we have hopefully one big ambition, and that's to make our medicines affordable for every US patient. I think that needs to be the remit for all of us, whether you are working for a PBM, industry, whether you are a policymaker or a politician. Now, if you have that belief, I firmly believe that we need to work together in a collaborative way. Out-of-pocket costs are too high in the United States. Personally, I think there are too many rebates. What can we do to rechannel some of those rebates directly back to patients? And my last point clearly is value-based agreements need to be more and more important in the US healthcare system, like they are in many other countries in the world, like in Canada, like in many European countries. Those are the three elements I think we need to work on altogether.
Look, one of the things I've been fascinated in, and you've addressed it with, PBMs, pharmacy benefit managers, there are insurance companies that are part of this equation as well. Clearly drug companies are, and then there's a very interesting social contract between companies like yours and then the generics industry. There's a complexity there so that, investment is incentivized and eventually it moves on to others. But it seems to be that when you talk about, how a drug gets a price, there are lots of different ways and players in that. Why do you think, would it be a bad thing for a bipartisan effort to bring all players together and say, how can we make this system better without undermining innovation? Because I think that's one of the tensions here is, are there steps that could be taken by government or others that would really undermine that very creative edge of the American innovation industry or the kind of broad global innovation industry and biopharmaceuticals?
No, it's a great point. First of all, I firmly believe in collaboration. Yes, we are working for different industries, but I truly believe that all players in the healthcare sector have one ambition, and it's to help patients in order to deal with their disease. So there's a level of common ground. Equally, let's not forget that despite all the challenges of the US healthcare system, the US healthcare system is probably one of the best systems in the world. And why? Simply for the reason that after FDA approval, most medicines are available the next day. While in Europe and many other markets in the world, you need to wait for at least 1 to 2 years before reimbursement has been settled. And that's a huge advantage. The second piece is it's an open market. There's price competition, and hence companies are sharp in order to price their drugs at a level which is competitive. And I think that will benefit in the end of the day the patients. Once again, where it goes wrong is that the out-of-pocket cost of patients are far too high. And I think it's everyone's obligation in order to think creatively what we can do in order to help patients. We need to have politicians with a clear view. We need to have clear PBMs opening the doors and the windows in order to be open for alternatives. And equally, the pharmaceutical industry needs to be open in order to make concessions. We cannot continue the way it's currently is moving forward.
Just finally, and this may be a very unfair question, but I'm inspired by it, by the background behind you, which is so cool. I think at some level, if we were to have this conversation 10 or 15 or 20 years ago, and I asked you 20 years ago, what is the future of science going to produce by way of products and responses to a lot of these ailments, which you outlined earlier? So we're 20 years ahead from when we might have had that conversation. Now we have, decoded the human genome. We have, so many advances in genetic therapies and what you can see into in terms of manipulating drug responses to ailments. And so if I were to ask you, what are we going to achieve as you are looking ahead, not just at tomorrow, but 10 years, 20 years, what is that world going to look like if we keep the innovation piece of this going strong?
Now, first of all, I firmly believe that the science is developing itself with light speed. And you haven't asked me any question about the COVID-19 response. But how incredible is it that 18 months now into this terrible crisis, we have 4 or 5 fantastic vaccines in order to try to protect people around the world. And that's because of the science, that's because of the innovation. If I fast forward myself in 20 years, I really hope that the area of tissue regeneration will be reality. If you have had a heart attack and a part of the heart became ischemic because of the heart attack, the pump function is severely deteriorated. How wonderful would it be if there are medicines or other stuff in order to regenerate the heart muscle, and therefore the pump function in itself remains intact. Now that sounds now science fiction, but it is truly the way we are thinking as an organization like AstraZeneca. And I know that many other companies in our space are thinking beyond what is possible now. And that's a very exciting and inspiring thought.
Well, listen, I purposely did not ask you about COVID-19. I do want our audience to know that historically, what has been achieved in these vaccines in such a remarkably short period of time is practically miraculous. It's never happened in history before, and it's there. I also wanted to kind of move beyond and have a discussion with my guest around the broad innovation sector within pharmaceuticals. So I really want to thank Ruud Dauber, Executive Vice President, President of Biopharmaceuticals Business Unit of AstraZeneca. Thank you so much for joining us today. Love your backdrop and love the conversation. Thank you.
Thank you.
And now for a message from our sponsor, Pharma. Please welcome Lisa Joldersma, Senior Vice President of Policy Research and Membership at Pharma. She's in conversation with Luke Greenwald, Vice President of the Market Access Center of Excellence at IQVIA. Lisa, over to you.
Thank you, Steve, and thank you to The Hill for hosting today's incredibly important conversation about Medicare. For nearly 2 decades now, Medicare Part D has provided access to life-saving treatments for seniors and individuals with disabilities. The program has been very popular, with more than 90% of enrollees extremely satisfied with their coverage. And yet, out-of-pocket costs have been rising for too many enrollees in Part D, leading to calls for reform to the program that might range from modest tweaks to more comprehensive overhauls. Today, I am joined by Luke Greenwald, Vice President and lead of the Market Access Center of Excellence at IQVIA. Now, IQVIA recently released a study that shows alarming trends in patient out-of-pocket costs within Medicare Part D. Luke, thank you so much for joining me today and for sharing a bit more about what you and the team at IQVIA released in this study.
Thanks, Lisa, and thank you to The Hill and our audience for allowing us to be in front of you today. Start with the simple truth. The more a patient is asked to pay, the less likely they are to do so. This is true across therapeutic classes, products, and demographics, although there can be great variation across those. For example, if you look at diabetes and anticoagulants, one of the metrics that we like to look at is new patient abandonment. So when a patient first goes to the pharmacy to try to fill a prescription, what's the likelihood of that patient actually being able to do so? And this is highly cost sensitive. For example, in diabetes and anticoagulants, that new patient abandonment when a patient is asked to pay between $30 and $40 is about 15%. However, if that patient is asked to pay greater than $250, as is often the case with coinsurance, then abandonment skyrockets to 56%. But it's not just abandonment, it's also adherence. So it's a patient's ability to stay on that medication over time. At those same price points for diabetes and anticoagulants of $30 to $40, we see a patient stays on therapy for about 218 days or 7 months. Compare that to, again, where that coinsurance might sit with greater than $250 of copay exposure. That adherence drops down to 45 days or about 1.5 months. So patients are on average almost 6 months less adherent when they're faced with higher copays. So patients exposed to these coinsurance levels, benefit designs, and on average, we know that they're more than 4 times as likely to have some of these challenges with abandonment and adherence as patients facing regular copays.
Yikes, Luke, those are some really big numbers. And just to be clear, for the most part, we're talking about branded products here, right, in the diabetes and anticoagulant space.
That's correct. So yeah. Branded products, although there is cost sensitivity with generics as well.
Of course. So just speaking again from your data and your experience, Luke, what do you think is driving these trends in Medicare Part D?
Yeah, the payers are increasingly using patient cost sharing as a mechanism of control. So benefit designs that have coinsurance as compared to regular copays are increasing in frequency. In the report that we just released, we saw that a whopping 92% of all Medicare patient spends coming from a coinsurance benefit design, as compared to only 8% when patients have traditional copay benefit design. So that's a big difference. Well, one of the challenges here, Lisa, is that there's a growing disconnect between the net price that a payer may be paying and the list price through rebates that manufacturers are paying to support the utilization of a product. Coinsurance is set off of the list price of a product. So it's not reflecting these savings that manufacturers are providing via the forms of rebates.
Luke, I know that your analysis really focused on Medicare Part D, but can you talk a little bit about what you're seeing in the commercial market and how those numbers look, whether they're better or worse or about the same? I know in the commercial market, for example, many people have deductibles that can be well upwards, of $2,000 or even $3,000 before they get any coverage. I would assume that's a big deal.
Definitely, Lisa. When you look at the commercial market, the same truth holds true that the more a patient is asked to pay, the less likely they are to do so. However, unlike in Medicare, patients in the commercial channel can use manufacturer assistance through drug coupons to lower their cost exposure. As such, classes like what we just talked about with diabetes and anticoagulants, if we use those as a reference point, patient abandonment when patients use a drug coupon is only 2%, compared to the 15% we see in the Medicare populations. One of the challenges in the commercial market that exists for specialty products in particular, though, is the utilization of accumulator adjusters. Which disallow manufacturer assistance from counting towards a patient's deductible. That can cause patients to face copay surprise when their benefit design expires. These accumulator adjusters then can also have a disparate impact on patients in at-risk populations and really contribute to healthcare inequities for minority populations.
Well, Luke, thank you so much for sharing your insights today and for digging in a bit more into your team's research. We so appreciate your time today.
Great. Thank you, Lisa. And thank you to the Hill for sponsoring the event. Just the piece I'd ask you to remember as we close out from this session, the more a patient is asked to pay, the less likely they are to do so. In Medicare, where patients who are on fixed benefit designs and fixed incomes are faced with co-insurance, it can be really challenging to get on much needed medications.
So true, Luke. Thank you. So obviously these trends are really disconcerting, and they seem to show that Part D enrollees are bearing a larger and larger cost for medicines or failing to fill their prescription altogether. And this trend really has happened over many years, but we need to address it now. From pharma's perspective, which I would add is shared by many patient groups and advocates, those in Congress who are calling for the government to set prices for some medicines, whether it's through negotiation or anything else, they're really proposing to let the government decide what medicine should be available in Part D to patients and to their prescribing healthcare professionals. And this is because they are proposing negotiation as a way to save money, up to $500 billion in the case of HR 3, for example, which really sounds too good to be true, right? That we can save billions of dollars without harming access. Well, that's because it is. But the good news is we can lower out-of-pocket costs without sacrificing choice or access to medicines. And pharma actually released a comprehensive agenda earlier this year that I'm really proud of. It would make medicines more affordable without compromising access, innovation, or health equity. We call it Building a Better Healthcare System, and the proposed improvements to Part D would bring direct relief to patients by ensuring those rebates that Luke mentioned get passed on to the patient at the pharmacy counter, by capping what patients have to pay out of pocket each year for their medicines, reducing the average cost of medicines earlier in the Part D benefit, and allowing patients to spread their out-of-pocket costs over the course of the year. We need to protect Part D and the robust access to medicines it provides so seniors and people with disabilities can continue to live longer and healthier lives. And as Luke mentioned, the issues of patient affordability extend well beyond Part D into the commercial market. And so our agenda also supports fixing what is skewed in today's system so we can try to make insurance work like it was intended to. And the things we need to do there are ensure more medicines are covered from day one, not after a multi-$1,000 deductible, making sure copay assistance counts towards beneficiary spending to avoid those pharmacy surprises that Luke mentioned, having more predictable and affordable cost sharing, and sharing rebate savings again with the patients at the pharmacy counter. And with that, I will turn it back over to you, Steve.
Lisa, thank you so much. And Luke, thank you for that very interesting conversation. My final guest is Randall Ruta, CEO of the National Health Council, a nonprofit association of patient advocate health organizations. Randall, great to be with you. You know, I'm looking right now as we talk on your website. It's fascinating. I just said, what's in this? You know, I've been talking, you know, why can't we just get everybody together and solve this? Well, I mean, you've got the Lupus Foundation, the Kidney Fund, the American Diabetes Association, Heart Association, but then you'll have Pfizer, Alexion Pharmaceuticals, Bio, Cigna. And so you actually are the place that, in a way, convenes many of the stakeholders in this healthcare debate. And so my question is to you, why can't you just fix all this?
Well, Steve, I came to the National Health Council about 6 months ago in this role as CEO. I've been associated with the Health Council for more than, my whole career, more than 30 years. And I agree with you. This is the place for us to problem solve together. The National Health Council represents patients, about 160 million patients that have chronic conditions, complex conditions, disabilities, who are represented by all those patient groups that you saw on our site. More than 140 different organizations are part of the National Health Council brain trust, if you will. And we're actively engaging with members of Congress, with the private sector, with anybody who's making decisions about, and we would encourage with, patients to move forward in a way that enhances access and improves outcomes for all patients in an affordable and equitable way.
Well, let me just ask you some point-blank questions as a layperson. Sure. I can't pretend, you know, just listening to Lisa have a very sophisticated discussion. You know, I'm coming at this as someone on the outside of this, but when I was talking to Dr. Seshamani, she's just very, very direct. You know, she wants the government, wants the Biden administration wants to, as a government, negotiate directly with pharmaceutical firms rather than those pharmaceutical firms, you know, negotiate as they do now privately with pharmacy benefit managers and other actors to try. And they argue that, you know, they're providing, you know, very robust benefits across, you know, various particularly pharmaceutical options. But what is lost and what is gained if the government would take this role? Are we overestimating what the government can do? I'm constantly amazed that the government thinks it can do all the things it can do, and, you know, very regularly disappointed in what the government does. But I mean, how do you feel about that pretension that the government can insert itself into that and interfere in that private activity?
Well, you know, we absolutely are encouraged by the interest of the Biden administration, certainly many in Congress that really want to improve the benefit under Medicare in prescription drugs, but actually in all of the different services and supports that are there for people who are older, people with disabilities that are covered by Medicare, whether it's under Part D or Part B or all of the different services that are provided, including those where the plans themselves through Medicare Advantage are playing a creative role in bundling services and supports and access in a way that invests in beneficiaries so that they can achieve their greatest health. But for the government to come in and look to foreign countries for a pricing schedule, to set limits maybe based on inflation or other kinds of factors in what we know is a very complex system with lots of incentives. We heard other participants talk about rebates and other ways in which the system incentivizes both players in the system as well as hopefully passing savings through to patients. Having the government really look to, like I say, the foreign countries for their pricing structures, direct negotiation. As we've looked at the proposals that have evolved, we've not seen necessarily that the savings could be achieved in ways other than pure cost cutting, or that really took into account what's most important to patients. And so my caution in looking at some of the proposals that have been floated is that we have to make sure that we're looking at unintended consequences, that we're focusing on things that are important to patients, patients, we ask a lot of patients in contributing to their own health, leading a healthy life, taking their medicines as prescribed, following through on doctors' therapy orders, whatever the instructions might be to achieve their health. That's what our patient groups are promoting. And so we need for this approach to be holistic. And what we've seen so far in proposals around negotiation or pricing structures is it's really all about cost. And I don't think we're going to get the outcome we want for patients or for society, certainly for these programs long term, if that's where we limit our thinking.
Thank you for that, Randall. And I also talked to the Deputy Administrator, Dr. Seshamani, about the rumors that in the infrastructure bill there was be kind of a, what I would call a takings or a drawdown or a, capture of some of the funding in CMS for road work and potholes and stuff like this. And I guess my question is that a danger if it turns out to be true? And I have to tell our audience, we don't know what is true yet because the actual legislative language is not out there, but we know enough that in fact there are folks that think that and the Biden administration thinks they can draw money from that element that was designed to help get patients at the counter more to lessen their out-of-pocket expenses. And is it smart to kind of use that as a fund to fund other priorities of government like broadband and stuff?
Right. And I think that is a danger in these big packages. You're not quite sure, how one part of a package might affect another. But, the bottom line for us is that if savings can be achieved, and there probably are ways to find savings, I would want to see those savings come right back into investing in patients in a way that lowers costs and improves their health benefit. So certainly, as we look at some of the proposals that are out there, having any funds that are able to be leveraged through savings or other ways, having those come back to those patients either directly at the pharmacy counter or indirectly through improved access to care, to medicines and services, because there are so many gaps in our system still. I was really proud to be a part of the effort to create Part D and then see it implemented, which is an amazing task of public-private, collaboration. The entire community was involved in helping seniors and people with disabilities understand this new benefit at the time. We've been evolving it over time. The extent to which we're going to look at places to find some savings within the current system, let's make sure that any benefit of those savings comes back and first and foremost benefits the patient in their health. Because that's where we're going to really see the ability of Congress and others to celebrate what's been a strengthening of a benefit as opposed to a transfer of resources to other compelling needs. But there are so many needs in the healthcare community, as you know, and having those savings, those ways to find value, stay within the system for patients is the best approach.
Randall, I'm going to ask you a out of left field question, but you seem to have all the players in this world. One of the things we've been struggling with, and I'm very happy that in your Twitter feed you had a salute to Disability Pride Month, that this month is about respecting and thinking about those folks with disability. But when you think about inclusion more broadly, not only the COVID response, but frankly, it's been there for a long, long time. Healthcare and health provision, how we reach people, is very uneven in parts of this country. If you go to greater Baltimore area, there are districts where you can have 20 years difference in life expectancy. And we hear a lot about the absence of trust. I talk to lots of Black and brown community members, patients, who say, hey, in the healthcare system, we don't see people like us. I guess my question is one on inclusion and diversity and healthcare. We're talking about costs and whatnot, but aren't there other dimensions of access and provision that we ought to be including in programs like this so that we make sure that as we look at this ecosystem, we're not accepting the situation as it is, that somehow we're building trust with these communities that for whatever reason either can't afford or can't have access or choosing not to because they're not sure they fit in. I don't know how to put it any other way, but it just seems to me that ought to be part of this discussion.
Well, you're absolutely right. One of the things that the pandemic did is shined a very bright light on how many areas of gaps and areas of inequity exist within our healthcare system. And so more than a year and a half ago, all of the members of the National Health Council, including the pharma groups, other parts of industry, clinicians, researchers, and all the patient groups launched an initiative around equity to make sure that as we think about healthcare holistically, we really focus on the individual, the patient, their family and community, and look to close those gaps and build that trust in a way that then will support people in their own health and really start us down a path to end that systemic racism that has occurred, or those consistent and persistent gaps that have emerged over the years, to really put those to rest. And what better place to do that is healthcare, but you have to think of healthcare more broadly. That's where this conversation around social determinants of care. It's not just healthcare, but it's access also to clean water and groceries and a secure home environment. These are all things that add up to a greater sense of health and well-being and really support the community. I think we will not see the kind of economic recovery, the return to work, the kind of participation we're looking for in society until we look at healthcare and then healthcare holistically, as you just suggested, Steve.
Randall, we are taking questions to the audience, and we have a good question from Christina. Christina?
Hi, my name is Christina Badaracco. I'm a research scientist at Avalier Health. I'm also a registered dietitian. In today's discussion about how to improve Medicare for patients, I would like to know what the speakers think about how Medicare should be updated to improve nutrition care for patients, thereby improving their health and reducing their healthcare costs.
Terrific. Your thoughts?
Well, Christina, that's a great question and observation. I think I've heard other speakers mention that adherence and compliance, helping patients just follow the prescribed regimen from their physicians that they're a part of evolving, is key. And so when you think about nutrition, particularly for people with chronic conditions or complex conditions, their nutrition is going to be as important as the medicines they take, as the interventions that might support their health in other ways. And so we would really like to see Medicare always take that holistic perspective. There's a lot that we could do around the prevention benefits that were added a few years ago to make sure that everyone, particularly with a chronic condition or complex condition, is absolutely taking advantage of the prevention benefits that already exist, looking to communities support us in doing that. In nutrition, again, particularly for people with rare diseases or many diseases that really affect the body's ability to absorb nutrients and achieve a balance that's necessary for health, knowing that that's as critical as any medication is key. So I think you've really touched on something very important and something that we would like to see go forward as we think about improving this benefit.
Randall, I'm just going to sneak one more question in.
Sure.
I keep telling people, I said, when I kind of get insights from smart people like yourself or like our guest from AstraZeneca, that I sort of feel like the technological change and options that are coming in to enhance our collective lives and quality of life are staggering, but that if Galileo were alive today, he might still very well be found guilty. And so there's this struggle kind of, and almost a sort of, there's an ambivalence about science and what it can do in some quarters, and I just sort of feel like hey, we're still in a period of pandemic. Science has been so important to that equation and coming up with options, and yet there doesn't seem to be as deep an understanding of how important this ecosystem is. And you sit with a lot of players there. Is this discussed? Do people wonder, wow, we need to kind of take a road show out there and begin kind of getting people to understand what is the missing piece of this? Or is this just the way it always is throughout history? Science is sort of taken advantage of, but yet not deeply embraced. I don't know. I'm just sort of, this is really a completely open air question.
Well, it's a great question because we are seeing that effect right now when having almost an accelerated and miraculous bringing to market of these vaccines that are helping globally us address this pandemic. And at the same time, there's a suspicion about the systems or the timing, the approval processes and things. So for the National Health Council, we have always been a close partner to the FDA, the NIH, the CDC, those institutions in government and in the private sector, many of our own members that are in the pharma industry and other industries that are so supportive of good science and careful about anything that comes to market, anything that's going to benefit a patient. And so I think the thing for us to do is just meet patients where they are, with their families, in their community, work with them in concert with their physicians to help answer the questions that they have relative to why this medicine, what do they need to know about their conditions, how can they be a part of their own health. And so with the current debate, making sure that the FDA has the resources it needs to follow a process, which is a trusted process. We're actually hosting a conference in October called The Trustworthiness of Science and Trust in Science, those two concepts side by side to get at exactly what you're suggesting. But the patient groups in particular, in partnership with the clinicians and the academics and the industry, absolutely are focused on making sure that people can count on the medicines that they take, the prescriptions or prescribed recommendations for them to achieve their health, and trust in that. And the most important way to do that is engage those patients at every step in the way, through education, through participation in clinical trials, through active collaboration with their peers and their physicians and others, so that they feel that they're a part of the process, they understand it better, and as you suggested earlier, they see themselves in a process that we know is dedicated to their health, but it doesn't always feel that way. And that's progress that we can make together, and it's not that far off if we focus on it.
Well, Randall, I hope you will let me and us at the Hill know about that conference you're doing. It sounds very interesting and would love to see what it is. I want to thank Randall Ruta, CEO of the National Health Council, and tell our audience that Randall's with 36 years at Easter Seals, one of my favorite organizations, does incredible work. You talk about inclusion in different corners, of the health picture among seniors, veterans, others. Very important, was President and CEO there. So Randall Ruta, thank you so much for joining us.
Thank you so much, Steve. Really appreciate this session today.
That brings us to the end of our program today. A very big thank you to Pharma for its support of these conversations, and to all of you attendees for joining us today for this discussion. For any of you who missed these conversations or you want to share them with others, we will have the video up on our website shortly. I'm Steve Clemens. Be well.